culture around interest in healthcare economics, which is such an important field for the university and, of course, for the world. My name is Professor Jennifer Milam. I am our Pro-Vice Chancellor of Academic Excellence at the University of Newcastle. Very privileged to be here today and grateful to my colleague Francesco Paolucci for inviting me. We've been working more together through the CFAL Newcastle, which currently I'm also director of, but getting great input and advice from Francesco on ways that we can more embed the work around the United Nations Sustainable Development Goals in everything that we do at the university. So I'm very pleased to be here to open this first of the seminar series dedicated to the future of healthcare financing that is brought to us all by the group, the Value in Health Economics and Policy Network. So Francesco, who leads the group, who I think you all know very well, is also joined today by our colleague from the University of Lucerne, Lucas Cower. And I don't want to say too much more, except also very importantly to do the acknowledgement of country. I'd like to acknowledge the Awabakal people who are the traditional custodians of the land on which we meet. I'd like to acknowledge their elders past, present, and emerging, and also to extend my acknowledgement to First Nations people on the land in which you may be joining us. And to say how important that is to us as a community at the University of Newcastle. So I'm going to pass over to Francesco right now and look forward to the discussion.
Thank you, Jennifer. Yes, use your notes as well. It's nice to see our presenters online and really thank you in particular to Tom McGuire, Professor McGuire, that is connecting, and Josefa Enriquez that are connecting from the US at a very late hour. So I am really thankful for your contribution today. Now, I will spend a few words introducing our presenters first. Professor McGuire has been a long-standing health economist looking at many of the key and critical issues that have been at the forefront of many countries' policy dilemmas. In particular, his contribution to the disciplines has been well recognized in a number of areas. I have the luck, and Lucas and Josefa and many others, to meet him and work with him on a number of research projects, mainly in the health insurance risk adjustment area. In fact, he's also a member of the Risk Adjustment Network. Tom is part of the international panel of academics that has contributed to the work that we have done together with Richard Van Cleef from Erasmus, Manos Mentsakis from Southampton, and Josefa, indeed, around really evaluating the current regulatory and incentive tools that govern the private health insurance market and how that interfaces with the public system. So welcome, Tom, and thanks for being here. The second presenter of today is Josefa Enriquez, who is originally from Chile, where in fact where we met the first time and worked on healthcare reform in that country. She was leading the data analytics group in my team back there, and I think that's when they met the first time with Tom, who was also involved in that exciting policy work. That culminated, in fact, in a visit there to advise the ministry and his team about I would say, the advancement in risk adjustment research in particular, but more broadly at competition and regulated competition in healthcare, which is very much the core of our discussion today. Josefa has been pivotal and extraordinary in our efforts in our work with the Department of Health and Affinity Australia, who I would like to acknowledge. In fact, Andrew Matthews was our contact, and of course, one of our collaborators together with Jamie of Affinity. Couldn't be here today because of a conflicting commitment, but I would like to thank him and also thank the Department of Health for working with us in the past couple of years, in fact, to produce this body of work. So thank you, Josefa, for being there as well. Now, I would like to briefly introduce also the panel members. So Dr. Lucas Kauer is a researcher at present in Lucerne, also a member of the Risk Adjustment Network. Is been working in the health insurance sector for a number of years. In fact, he was part of CSS, which is not only health insurance, but unlike many other countries, they have also very strong research units that has produced, together with Konstantin Bach, Maria Trotman, and others, a very, and also Tom, in fact, looking at Swiss data, a very important contribution to understand how we can improve the way in which we regulate the insurance markets. I'm very thankful for Lucas' presence here today, and also for Share at UTS that brought Yuka to Australia, and the colleagues there that, in fact, have mutual interest and collaborate. So thank you, Share, Jane, Rosalie, and Mariam, that work with you. I think maybe they're even connected. So please, welcome also to you to this forum. Now, I'm very, very pleased to have Hannes Boshoff. I'm sorry for the pronunciation, Hannes. I lived in the Netherlands for quite some time, but it's a very difficult language, and maybe your last name is not Dutch at all, so I apologize for that. You are very welcome to join us today, and Hannes is a fellow of the Actuary Institute of Australia, and is currently Chief Actuary of HPF. If I understand, he's South African born, and he completed his studies in the Institute of Actuaries in London. He has held a number of jobs and roles in health funding industry in South Africa, with a very profound knowledge of different ways in which we look at data and data modeling. So Hannes has also been a very important and vocal contributor throughout this process when we engage with industry. So thank you for being here today. Now, a couple of corrections. We were supposed to have a member of the AMA who couldn't come, Katrina, Katrina Bassett, but she promised she will be there next time. She had a family commitment. We also have had a last-minute cancellation as well from Alex Robson, who is the acting head of the Productivity Commission, because of some pressing commitments today. Also, I would like to present our final panelist that is joining us, I believe, from Canberra. Somebody who I've had the pleasure to work with at the time of the National Health and Hospital Reform Commission, when in fact Sean Gaff was the director of the regulator of the private insurance market. In recent year, FIAC changed its, let's say, the whole regulation was basically absorbed by APRA. So we're very fortunate to have Sean here, who is currently consulting. Now, without really spending much more time on presentations and thanking you one more time, I will basically give the mic to Josefa, I believe, who will be the first presenter. If I got that wrong, Tom, and you are the first, up to you. So I think I got it right. Josefa, you go ahead.
Thank you. Thank you, Francesco, for the introduction. So I was just wondering if you want to take questions after the presentation or at the end of the session.
It's really your preference. I would probably thank you for making this point. I would probably recommend people that are on Zoom to really use the chat to interact with us, so that we probably can collect the question. If you have something urgent, maybe put a UQ, urgent, U. So we look at that and we try to see whether there is room, and I'll try to intervene. And for the rest that are in the live streaming, write me via email. I'll monitor my phone and I'll moderate that. So pretty much the answer to your question, Josefa, you tell me what you want. I'll collect the information. You decide, and Tom as well. Thank you.
Okay, thank you. So thank you everybody that is there in the room and the people that are connected online. So the first presentation that I will be talking about is part of the so-called actuarial studies that were commissioned by the Department of Health. And in this paper and in this report, what we were studying was basically the current risk equalization scheme in Australia. So this report we titled Combining Risk Adjustment with Risk Sharing in Health Plan Payment Systems. And we're going to be looking at the case of private health insurance in Australia.
Sorry, Josefa, can you share your slides, please?
Yes, they're being shared. Sharing the screen.
Okay. That's 1 second. We don't seem to see this.
I'm not sure it was part. So is Josefa sharing your own? Can the other presenters see the slides?
Do you, Agnes, Sean, you see the slides? Okay, yeah, we don't see them here.
Yes, I can see them.
Okay. I would say.
I'm in the title, so.
Yeah, very good. I
haven't
would
missed anything yet.
I would suggest you go ahead and proceed. We'll catch up when Patrick fixes the problem. Please proceed.
All right. So the context that this work was embedded in was the context of private health insurance in Australia. And what we have to understand, first of all, is that risk equalization in this context comes to support what is called the principle of community rating, and particularly the regulation around the community rating of premiums. So basically, private health insurers in Australia cannot differentiate their premiums according to individuals' characteristics, but rather the premiums of the plans have to be the same for everyone that chooses to enroll regardless of their risk. So at present, the regulator relies on risk sharing to mitigate selection incentives. So basically, because there is community rating, what happens is that as the expenditures might be different in practice, there's going to be certain groups of populations within the system that are going to be profitable for insurers, and some that are not going to be profitable for insurers, incentivizing them to exert certain actions to select. So we're going to be looking at what risk sharing, what we understand by risk sharing, and why we're calling the risk equalization scheme in Australia a risk sharing type scheme. So the disadvantage of the current risk sharing scheme is that it really reduces the incentives for cost control from insurers by around 47%. And we're going to show this and explain this a little bit more in the following slides. So the key question that we ask ourselves was, can risk adjustment, or a combination of risk adjustment and risk sharing, outperform the current system? So by risk sharing, what we mean is that the payments to insurers are based on the actual claims cost of enrollees, so the actual spending of enrollees in the system. And some of the examples of risk sharing include proportional risk sharing, which is basically payments based on a certain percentage, for example, as in Australia, of the actual claims cost of the actual spending in the system. And also this could be in the form of reinsurance, which differs to the proportional risk sharing as it's based on individual level claims costs above a certain threshold, a certain amount. So one of the main advantages of risk sharing is that it's quite straightforward to implement. It's not as data intensive. Kind of what we need is basically spending. This is likely to be recorded by insurers. Of course, it is recorded by insurers in Australia. So in that case, that's one of the pros of this types of scheme. One of the cons, though, is that because I'm sharing actual expenditures, this will reduce the incentives for cost control. So on the flip side, we have another tool that is used to mitigate incentives for risk selection, which is risk adjustment. And in opposition to risk sharing, this will mean basically payments to and from insurers, which are based on indicators of expected or predicted claims costs. So some of the indicators can be age, prior diagnosis, gender, and many more that are used in practice. So the example of this is basically payments to insurers for their predictable losses on groups such as older groups or individuals that are more high risk, that are unhealthier, and repayments from insurers for predictable profits on younger groups. So there's going to be transfers from those that have younger populations towards those that have, for example, older population or more high risk populations. So the main advantage of risk adjustment will be that it will certainly retain incentives for cost control. And this is because we're setting some of these payments in advance. So basically, any payment of any spending above the payment will be a loss for the insurer. So they have some incentives to remain within the amount that they have received. But a con of this type of system is that definitely risk adjustment are more data intensive. You need individual level information, you need individual level spending and information that is detailed, for example, on the age, on the diagnosis of individuals, and so on. So the implementation of more sophisticated schemes will require some time and some iterations. So what does the current risk equalization or so-called risk equalization that is in place in Australia look like? So on one side, this risk sharing scheme, as we called it, because it's based on actual spending, has what's called the age-based pool, so the ABP. And this is basically a scheme that will share a percentage of actual claims. That this percentage is differentiated by age, as we see here. And then also that is supplemented by what's called the HCCP, or the high cost claimants pool, which basically net of the payments that have been made by the ABP will share above $50,000, 80% of those residual claims above that threshold. So the issue with this system, as we compute in in the paper is that the reduction in cost control incentives is quite large and around 47%. So what this means in practice is that if an insurer can bring down spending by $1, 47 cents will basically be shared within the market, and then the remaining 53 will be what the insurer is actually keeping. So that's how we can understand what this 47% means. So in our simulations, what we were trying to do is assess, again, if other types of models would fare better than the current system. So the models that we're going to be seeing are based either on risk adjustment only or on a combination of risk adjustment and risk sharing. And we start by looking at the current model, which we have classified here in the column of risk sharing. And then we'll have a look at simple models that are first based on just age and gender. So we weren't trying to compute very sophisticated models. We were starting with something simple. And then we also added a simple measure of morbidity based on a yes/no indicator if an individual had an hospital episode in the prior year. These two models, which then become models 3 and 4, were supplemented by risk sharing, in which we set a threshold of $20,000, and above that threshold, we were sharing 90% of the cost above that amount. So what data were we using to do these simulations? We use data from insurers for 2 years. So we must say that we thank the cooperation of insurers in this regard, and the work from Finity to put this all together. And we were using the years 2019 and 2019, and around 8 million enrollees from private insurers. The main variable that we were using for our estimations, our claims cost, was basically the spending that was reimbursed by insurers. So what this means is what the insurers were responsible for, and we were not including any form of out-of-pocket payment. So the main characteristics in our models, as we saw in the past slides, going to be age, gender, and also hospital episodes. We also looked at additional simulations, which considered another feature from the Australian system, which is the fact that products now can be classified into these 4 groups, into basic, bronze, silver, and gold. Basic being the more simple one, and then gold being the more comprehensive one with more clinical categories included under coverage. So what are we going to do? First of all, we simulate these models that I talked about in 2 slides before this. We will estimate them, and for each model, what we will be doing is seeing if the payment that an insurer would receive based on the characteristics of their enrollees and what we have been including in the model as form of payments. We have defined certain measures to assess incentives for risk selection and for cost control. We'll be seeing what these measures are. We calculate these measures and compare the models against these measures. So as a bonus step, we also looked at additional simulations which basically assess the effects of these models on the redistribution of spending across these product tiers. So the 2 main measures that I'm going to be showing in this presentation, there are some others that were also calculated are, first of all, the measures that capture incentives for risk selection. And basically what this will capture is the predictable profits or losses for certain groups. So if based on the comparison between the models and the predictions from our models and the actual spending of individuals, if there is a profit or a loss for certain groups. So then the other measure that we're going to be using to compare the models across is cost control, and how this was calculated was by assessing the proportion of the actual claims cost shared in each one of the models. So one thing that is important to mention is that these measures are quite simple, and we'll see that they're quite straightforward. And the main reason for this is that we did want for this measures to be easily understandable by a wide range of audience and stakeholders, as we're talking about potential improvements to a policy and regulatory instrument. So what are the outcomes of our simulations? So here we have the models that we were assessing on the top two rows. And first of all, to mention how to read the numbers here. So basically what we are seeing in these results are the predictable profits, which are with a plus sign, and also the predictable losses, which are going to be in a negative sign. So in very simple terms, what we are seeing here is that in assessing the current system, as far as we know, this is also one of the first time that the current model, the current system of risk equalization in Australia has been assessed. Even if there are a differential payment by age, we still see that it does not level the playing field in terms of age, because we see that younger individuals, for example, from 0 to 54 years old, are attracting profits, and the older individuals, 55 plus, are generating losses. So then we also see this same occurrence in the groups that we're considering around prior hospitalizations, which basically intend to capture a degree of morbidity by the individuals. So as we mentioned, the cost control incentives are decreased by 47%. So an interesting finding to mention here is when we're including risk adjustment, and this is by definition of what risk adjustment does, is that we do not see any predictable profits or losses by age groups or also gender, which is included in this model. And this is by construction of how risk adjustment works. But what this means is that a model with risk adjustment would actually level the playing field across insurers in terms of the risk factors that are included. I'm not going to go through all the numbers that we're seeing in this table, but what's important to mention is that when we use the models that combine risk adjustment and risk sharing, which are Model 3 and Model 4, what we see is basically two things. And if we focus on the prior hospital episode groups, what we can see is that the Model 4, which includes age, gender, prior hospitalization indicator, but also risk sharing, the incentives for risk selection measured by these predictable profits and losses decrease substantially. And they decrease, comparing to the current system, it's less than in the current system. The other important thing to mention is that we are achieving improvements in terms of risk selection incentives, but also what we can see is that now there's more incentives to control costs because the percentage of claims costs that are shared decreased to around 23%. So from our empirical analysis, what we can say at the end of the day is that a system that combines risk adjustment and risk sharing is going to be better all around than in the current system. So my first conclusion, before I continue with a second part of the analysis, is that in Australia, the current payment system, which is primarily based on risk sharing, can be improved by introducing elements of risk adjustment. So more specifically, what we find is that incentives for risk selection can be reduced substantially, and also the incentives for cost control can increase. I think something that is important to mention is that risk selection in Australia, in the absence of private insurance having a standardized benefit package, will tend to focus on product differentiations and product exclusions. So this is something that risk selection that we can see manifested in that way, and therefore improvements that can lead to decreasing in this and consequently undermining the community rated principle and affordability could be implemented kind of regardless of how reforms move forward. All right, so in a bonus step, we also assessed in the context of Australia, which is a voluntary health insurance market and which is characterized by multiple products. These products are now classified, as I mentioned, in basic, bronze, silver, and gold. How payment systems, how risk sharing and risk adjustment can affect also incentives for consumers. So we're looking at how risk sharing and risk adjustment can affect the insurer's net claims cost per product tier. And by net claims cost, what we mean was the claims cost net of risk sharing, risk adjustment. So just in simple words, what we were trying to look at here is how, because the payment system will be redistributing money from gold to the basic plan, insurers will take this into account when calculating premiums. And this might then affect the decisions of consumers in this market. So just in simple, these are the 4 types of products in hospital treatment in Australia. But the main thing is they get more comprehensive while we are approaching gold. So what do the 4 tiers look like? So the first thing that we can see here in this graph is that the mean claims for these 4 products differ quite substantially. And this is, in part because they are covering more benefits, but also what we can see is that there is some selection occurring, as we can see that individuals that are older are choosing more bronze than basic, more silver than bronze, more gold than silver, and so on. In addition, we can also see this when we're looking at an indicator of morbidity by looking at the percentage that had a prior hospitalization. So we can see again this increasing pattern, meaning that there's some selection occurring. Okay, so in terms of what we were actually estimating, what we see here is First of all, in the blue bar, the mean claims cost for insurers. And this is in absence of any risk sharing or risk adjustment. So this is the actual mean claims cost for the different product tiers. And when we're thinking about the insurance market in Australia or in a competitive market, what we assume is that the premiums for our product will be based on these mean claims that the insurer basically has to reimburse. So we can see in this pattern that indeed there's an increasing trend. Gold products have higher mean claims cost than, for example, basic products. Now in orange, what we can see is the mean claim cost after the current risk equalization system, so the ABP and the HCCP, have been taken into consideration. So what we can see in the orange bar is that there is some redistribution between the gold to the basic. So a premium for the basic will basically go up because of the risk sharing system that is in place. What we see finally in the gray bar is that this trend is somewhat heightened when we're looking at the model 3 that we were estimating. So there is more redistribution, and this is partly because we are considering more risk factors in play here. So what we just wanted to flag is that this might be something that we want to consider. So if we don't take any additional measures, this may have some impact on the premiums of the different products that we might, as a regulator, the regulator might not want to see. So in the paper, we do discuss some options of how to deal with this, but that's not part of what we're discussing right now, but there's more information in the reports. So to finalize, the payment system reforms affect the distribution of claims costs across the different coverage levels. And in a voluntary market such as the Australian market, this may impact consumers' decisions as it's impacting premiums. And therefore, an interesting question to assess would be how to incorporate the objectives of the desired level of redistribution across the different levels in the payment system design. All right, thank you for listening. And I believe now I can give the floor to Tom. I think it's better if we take on some questions at the end and after the discussion.
I'll just go ahead then. I want to begin by thanking Francesco for inviting me this morning, and more generally for his leadership in the project. I'll be doing the talking about this topic, but it's been a joint effort, both by members of Francesco's team and also by members of Affinity. So the intention of the work that I'm going to describe is to identify some empirical parameters regarding the costs and the savings from government subsidies to private health insurance. The cost to the government of private health insurance is the subsidies that it must pay for individuals and families who join private health insurance. The savings to the government are the reductions in the obligations of the Medicare program that are attained if someone moves from treatment in the public system to treatment in a system that's covered by premiums. So how big are these costs? How big are the savings? How do they compare to one another? And how do they compare to one another for different groups is what is the subject of the analysis I'll be describing to you. And I want to acknowledge that although what I'll be talking about this morning has to do with costs and savings and government spending, government spending or reducing government spending isn't the sole or possibly even the most important objective of policy when it comes to private health insurance. It's certainly one consideration that a policymaker or a decision maker would want to know about. How much is the government spending on net to subsidize private health insurance? But there's other considerations, like support for the healthcare sector, like overall healthcare costs, like providing choice to consumers. All of these things are also potential objectives of policy. And it's very common internationally for governments to subsidize purchase of health insurance. The US has many different kind of sectors of health insurance. All of them feature subsidies from the government to encourage purchase of private health insurance. We have our Medicare program, which is mainly for older people, that is a public system, and the government subsidizes choice of private health insurance within the US Medicare system. I want to make one observation before I get started on the PowerPoints. And this is something I guess I knew going into this project, and I think many of you also know it, but I didn't appreciate until we got into the analysis the importance of the fact. And the simple fact is this, that someone who is 75-year-old, just to pick a number, has 8 times higher healthcare costs than someone who's 25-year-old. And what this means is if there's offsets that the government is enjoying by moving someone into the private health insurance sector, you get 8 times the offset for an older person than you do for a younger person. So if I were making a PowerPoint of this, I'd have a picture of Tom on one side, and I'd have a picture of 8 Josefas on the other side, and then an equal sign between them. And what that would signify is that from the standpoint of the government moving individuals into the private health insurance sector, it's 8 times more important to get me into private health insurance than it is to get Josefa into private health insurance. And that it's a fact. It's just a pattern of healthcare costs that's not specific to Australia is going to determine which of the groups are on net to the government costly or on net generate savings. Okay, so there's two big things I'm going to try to do in the next few minutes. I'm going to compute the costs and the savings in Australia for a nationally representative population in private health insurance, and I'm going to do it by group. The data that I have, that we have, has income categories and has age categories, so I'll be able to show that by age and by income. So you'll see who are the, quote, winners and losers from the standpoint of the government. And the second thing I want to do is to make a step in the direction of what does this mean for subsidy design. So we have subsidies, there's a certain impact of the current subsidies, but if you could change them, if you could raise the subsidies over here or reduce the subsidies over there, what would you want to do from the standpoint of minimizing government net cost of private health insurance? Okay, Josefa, my able assistant, is going to share the slides, please. I'm not done yet, no. Okay. All right, so we're going to talk about data just for a second here, Josefa. That should be the first slide, the data slide. Okay, so there's 3 sets of data. The first set has already been described by Josefa. It's the administrative data on benefits. We have claims data and we have enrollment data. The enrollment data includes information about income of the family or individual, and it has information about the age of the policyholder. All this is completely anonymous. I don't know which companies submitted the data. We have no way in the data set to identify companies, even in the aggregate like company A, B, and C. We don't know any of that stuff. It's just an overall aggregate of claims data, 8 million people in Australia. Of course, the policy parameters are known. The government subsidies based on premiums, the Medicare levy surcharge, which depends on income, are all publicly available and can be applied to these data to compute the subsidies that government contributes for each individual joining private health insurance. And then we have numbers of individuals in private health insurance from the Australian Tax Office that shows how many people of what groups by age and by income are enrolled in private health insurance. So that's what we have to work with here. Okay, Josefa. There's two forms of net cost I'll be describing to you. The first form is what I've been discussing so far, the net cost to the government. So the government pays in the subsidies, the government gets back any offset of costs due to private health insurance covering healthcare. Subsidies minus offset is the net cost to the government. If that's positive, it means the subsidies exceed the offset. If it's negatives, it means the other way around. Net social cost is the total private health insurance cost less the offset. Setting aside government subsidies, moving someone into a private health insurance product may increase their healthcare costs. If that happens, that's going to increase healthcare costs in the country. I guess the plus side is you're supporting the healthcare sector. The negative side is you're increasing the healthcare cost in Australia. So before we go on, let me be sure people understand what I mean by offset. So an individual enrolled in private health insurance uses healthcare. The offset asks the question, if that person had used that same pattern of healthcare, but had been covered by Medicare, how much would it have cost the government? So this is addressed in 3 different components of utilization. We do it separately for hospitalization, for medical benefits, and for prosthesis benefits. The details of that, are in our analysis, but we take into account the payments that the government makes towards the medical benefit in the private health sector. All right, go on, Josefa. Okay, these are some results. And what I'm showing you is by different age groups on the horizontal axis, and for different income groups according to the colors of the line, what the offsets are by age and income. So government subsidies aren't in this graph yet. This is just the savings to the government of different people at different age groups and income groups. And these are the single people because they're relatively easier to kind of interpret and graph. And what you see here is the fact that I mentioned before I began the presentation of the data, how much greater the offset is for older people than it is for younger people. If you go down into the 18 to 29-year-old range, independent of what the income of the individual is, the offset on average is of the order of $500. By the time you get into the 70 plus category, the offset pretty much the same for all the income groups, because this is just healthcare use. For all the income groups, it's not that different. And for the older people, the offset is $4,000 or $5,000. So the savings to the government of moving an individual older into private health insurance is much greater. Okay, Josefa. All right, so now I'm going to show you the net. The offset in the previous slide was all positive. That was healthcare costs. Now I'm going to do a net, which is equal to the subsidies the government pays less those healthcare costs. For groups that are positive, that means the subsidies the government contributes exceed the offset savings the government enjoys by moving that person into the private health insurance sector. So what you see here is that, first of all, for the higher income groups, there's a higher net cost to the government. Why is that? That's because of the Medicare levy surcharge. That's higher for the higher income groups, and the government loses that every time someone elects private health insurance. So the net cost, given the current subsidy system, is higher for the higher income groups, and it's also higher for younger populations. The subsidies that they're receiving exceed their relatively low offsets because they don't use very much healthcare. You have to move to the right of the graph to see where the government net savings are appearing. They're appearing for older individuals whose premium subsidies are somewhat greater than for the younger people, but on net, their healthcare costs that are offset are much greater. So that's where the savings to the government are by moving those guys to the right of the graph into private health insurance. Okay, Josefa. This is the second form of net cost I was speaking about, which is total healthcare costs. Moving people into private health insurance will tend to be more expensive. It's in this case, it's whatever the private health insurance spending is, less what the savings are in the public system. And here, the increase in total healthcare costs again parallels the overall level of healthcare utilization. The older groups impose or incur a higher social cost by moving into private health insurance than younger groups. Okay, Josefa. Okay, now that was what I just showed you was the overall accounting of the current system. And I didn't call attention to, but you may have seen in the previous PowerPoints, that on balance, the government saves money in private health insurance. It's something like $500 per person on average. The subsidies are less than the cost offset by, on average, for the population, about $500. So that seems like a good thing. It still leaves open the question of, okay, there are different net savings for different groups, and if we were able to modify the subsidies for different groups, what would you want to do if you could modify the subsidies in light of the findings regarding who is a net cost and who is a net savings? So that's what we call a critical value analysis. So let me go over these 3 points quickly. For groups that cost the government, that is, on net, the subsidies they receive are not offset by cost savings. If you are interested in reducing government costs, you would reduce the subsidy for those groups. You win twice when you do that. You reduce the subsidy, that saves money. And because fewer of them move into private health insurance, if the subsidy is reduced, then you save money twice, because those people in private health insurance cost you on net. So it's straightforward if you want to reduce government spending, what you do for groups that are net losers to the government. What about the net winners? There's groups that whose cost offset exceeds the subsidy they receive. What do you want to do with those? Well, when you increase the subsidy to these groups, you increase the subsidy to every one of the members of these groups, and that costs you money. In order for you to benefit on net from increasing the subsidy, you have to get more of those people into private health insurance in order to generate new savings. And that's where the critical value analysis comes in. What is the number, or what is the proportion of individuals in a group in which there's net savings that has to move from private health insurance, move from the public sector to private health insurance in response to your subsidy? There's a break-even analysis, and if the proportion moving is greater than that, an increase in the subsidy will lead to a reduction in overall government spending. Okay, next, I'll show you some examples of this. right. Skip that one. I more or less covered that. This is the empirical application of that. Okay, this is data from our project for 4 selected groups. The first group is the 45 to 49-year-olds. They're family policy holders. They have income of 180,000 or less. There's a group average subsidy. There's a group average offset. On balance, the offset is a little bit greater than the subsidy, so they're net winners. There's a lot of people in this group. And then the following rows calculate what would have to happen in response to a $1 increase in subsidy in terms of enrollment in order for there to be a net savings for the government. It doesn't seem very plausible to me. If you increase the subsidy by $1, you would need 5.88% increase in the number of people enrolled in this group in order for the government to save money. That doesn't seem likely to me, so I would not recommend an increase in the subsidy to that group, even though they're net savings. For the age 18 to 24, these are people with, they're pretty close, but the subsidy exceeds the offset. So for this group, you don't want to increase the subsidy. If anything, you want to decrease the subsidy. But then we have a bingo group. Bingo, this is what you're looking for. You're looking for a group that has big savings on net. This is over $3,000 offset greater than subsidy by the government. There's not that many people in this group, but if you increase the subsidy by $1, because the savings are so great per person, you don't need very many people to change from the no to the yes PHI in order for the government to save money on net. So this is a really good example of where you would want to increase the subsidy. And these calculations could be made for any groups or any sort of aggregation of groups if there was some sort of across the board kind of subsidy policy that was under consideration. Josepha, what's next? Okay, so I'm wrapping up. On balance, private health insurance generates offsets that exceed the subsidies. That seems like a good thing. Older people generate more of this net savings than younger people. It's not really a criticism, but it's always true everywhere in the world that the current subsidies are not the optimal subsidies to minimize government spending. And our project, our analysis, is a step in the direction of indicating if you could change the subsidies, what would you want to do in order to reduce government spending? That's it for me. Thank you very much.
Okay, thank you. You can hear me online, yes? Yeah, great. So thank you, Tom. Thank you, Josepha. Also, thanks for those attending. Very great turnout. And I see people from industry, the department, other colleagues in other universities here and overseas. So thanks for the participation. And please feel free to interact if you can with the chat, not the Q&A, so that I can have an easier way to deal with the questions. Now, I would like to start probably by going to Lucas and maybe the first question for the panel is, of course, and I'll go to the three of you with this first. What are your impressions about the Australian system? Of course, you come from the Swiss experience, Lucas. You can also reflect on that. But what are your impressions on the system and on the studies and so forth?
Okay. Thank you. Can you hear me? Yeah, it was very interesting to learn, particularly the first presentation was interesting to see that you're using 8.5 million people, which is exactly the population of Switzerland. And the system that you're looking at with age, gender, and hospitalization and risk adjustment was actually the system we had in Switzerland up until 3 years ago. So was kind of interesting that you're doing this simulation for Australia with almost the setting of Switzerland. Of course, the system are a little different. We don't have this split or the same split as you have here with kind of a public system and a private system. We have more like you sometimes say it's fully private, but it's heavily subsidized. You have a mandatory insurance market, and then you have a supplemental one, which is kind of similar to what you have here in the private one, but it's not like hospital, or there's not a split between public and hospital providers. And the second part was very interesting to me, kind of this exercise of the offset. I've never seen that. I've never seen that done in Switzerland. I mean, one reason is I just mentioned, probably couldn't do it the same way because we have a different system. But I think it's a very highly policy relevant question in what you're looking at of you putting a lot of money into with these subsidies, trying to incentivize participation in the private markets. What do you actually get out of this? So I'm really happy to see that. I'll leave it at that.
Beautiful, thank you. No, great. Now, Hannes, would you like to address the same question?
Yeah, sure. Thank you, Francisco. Thank you for the introduction as well, and for opening up this conversation. I think it's an important topic. I think one of the things that I've observed is that the current policy settings is doing quite a fair job of the overall keeping the whole system in balance. So my question more is around, what is the key problem that we want to solve? Because if the problem is understood differently, then the outcomes may be different. So just to put that bit in context, when we started the conversation around the reforms, we had a big focus on affordability and how to make it more accessible for more consumers to ensure that the system remains stable and sustainable. So you can have an affordability spiral and have things more expensive over time and still be sustainable. You will just serve a much smaller population of more wealthier people. And I'm not sure that is the intent of the reforms. So if we look at the reforms that has been done over the last decade, all of the reforms has been focused on more people that have immediate claiming needs. So in 2014, when we changed the rebate, for example, we reduced the indexation such that there's actually fewer support on a broad-based level, and we've also had more of the similar to what was proposed now or discussed during the studies, is the older people were supported more than the younger people. At the time, we started seeing since 2014 a rapid drop of those under 55 that participate in the system, with the drop of the older people being much slower. We also saw the mental health waiver coming in. We saw the more commoditization of the products where consumers can easily pick their benefits. So all of these things collectively over the last decade has actually brought the system, what I would say, out of equilibrium. So more and more of the younger people dropping out of the system. So if we are focusing more on affordability, we do need to look at how do we actually achieve that. And unfortunately, what I think of sawing in the current reform proposals is the focus has shifted quite a bit more to the government spending rather than how do we actually achieve overall system sustainability and affordability. So I think if I think, Tom, the specifically the critical value calculation of the losers and gainers in that system from that perspective, if those suggestions of supporting all the people are actually taken forward, then the original intent of actually getting the system more affordable for everyone would definitely go the wrong way, in my opinion. And I think also one of the other observations or thoughts that I had that I'm keen to understand probably more from the people closer to it is that the MLS as a tax construct that was introduced for the purpose of supporting PHI sustainability. So if that is seen as a cost to government, as a loss, you have to assume that tax would have existed in the absence of PHI, which is not the case. So if that was to remove, if PHI as a system were not there in the first place, then I think using the MLS as a calculation to say that that's a loss to the government, I think is also something that I would probably have a different perspective on. I would see that as that tax were only there because it was meant as a penalty or as a stick in the process. So I think overall, my overarching comments or thoughts with the first part is around, we need to think around the overall system balance and the second order impacts, and not only the first order of what happens when we change specific incentives right now, and what will it means for the system over the longer term. Francisco, I don't know if you also, I think on the risk equalization component as well, I think as well from a technical side, that is it's a very interesting study, and I think a lot of good work has gone into that. So Sefa, I think my question from my end will be, what I see from what you shared is that it seems like the price of bronze and basic covers will go higher in such a environment, which again I think comes back to that whole affordability question, is that, you know, will we achieve greater affordability under such a system? What we have seen from insurer perspective is that our profitability actually on the older people are good, because you also have a higher revenue. So even though the cost equalization may not be perfect across all ages, you do find a higher profitability in the current system under older people. So you know, I think my question with that work is, is there a practical way for us to balance it such that we actually can drive a more affordable options for consumers, and therefore also sustain the system over longer term? I think those are probably the nutshell my thoughts on the current state. There's a lot of other things that we can go on to, but we can cover that off if there's questions and stuff on the matter.
Okay, thank you, Anis. Very interesting. So to clarify a couple of things, so the MLS, just for those who have heard it for the first times, let's say, it's basically the Medicare levy surcharge. So Medicare is funded through a tax-based model. If you do not buy private health insurance and your income is above $90,000 per year, you are charged an additional contribution in tax, okay? And if you do buy it, that is exempted. Now, Tom, Josefa, do you like to have a reaction?
You go first, Josefa.
Okay, thank you, Hannes, for your main question. I think I would like to answer the affordability question in general in two parts. So I think what's interesting about improving a payment system, you know, such as the current risk equalization or risk sharing scheme as we're assessing in Australia, is that by improving that, we do see improved affordability for certain groups that we were assessing, because we are reducing the incentives for insurers to basically kind of discriminate against them through the product differentiation, and therefore kind of violating in this way the community rated principle, right? So if you have many products and you start to differentiate them more and more in different ways, in that way is how you can attract certain consumers, and the premiums for those different plans will be different, even if within them you know, the price is the same for everyone that buys it, but you know, among them the people that will choose certain plans, probably the most expensive ones will be individuals that are higher risk, and we want to protect through, or the government wants to protect right through the community rated principle. And then second, I think it's a kind of a good catch about the prices for the different products. And I think there are two different things that, you know, we do see indeed that the current system does redistribute claims among the different product tiers. So that's one thing. And then well, in this presentation, we did not qualitatively show how maybe we could preserve, if that's what the government wants, the existing redistribution in the alternative models. There are ways to do that, and we discuss them kind of qualitatively instead of quantitatively in the research report. If that is, a concern, that could be a legitimate concern by the government, that they don't want to see higher redistribution than currently, for example.
Yeah, I think that's a very good point. Is also related to Anne's point. So if affordability, it is a concern, and some may say that in a private system, maybe that's not the key question, but if it is a concern, then perhaps considering a mechanism that is in fact dealing with that in an explicit way rather than implicitly as it currently is, because cross-subsidization does occur, it's probably what needs to happen, because affordability is sort of a societal objective, definitely in general terms. Thomas.
Just quickly, I thank Hannes, thanks Lucas for your comments. On affordability, that's not a term that you would teach in an economics class. I think what it means here, or at least one meaning of it here, is to have the premiums not get too high. I think that's what Hannes was talking about, that if you let the low-risk people go for whatever reason and just have old people there, the premium's going to have to be high. So you could state, I think, the objective here as keeping premiums low to encourage enrollment in private health insurance would be, an interpretation of affordability. You could also make it affordable by subsidizing poor groups as an alternative. The MLS, the Medicare levy surcharge, is this really interesting thing that Hannes brought up that takes a while in this project to think, like, how am I going to treat this thing? And what we did was simple accounting. The tax regulations are what they are. And we just asked the question, if you move a person from the public sector to private health insurance, what are the implications to the government? And that involves both the MLS and the premium subsidies. That's what we did. It's, your philosophy of what the MLS is might, lead you to think about that, but that's what the accounting tells you.
Yeah, it's also interesting. It's applied to the purchase of private insurance. An interesting question would be, in fact, if you apply it to out-of-pocket spending directly, and then the whole discussion of affordability also changes. Sean, please, welcome.
Thank you. Well, thanks. First of all, Francesco, for inviting me. I'm pleased to be here, and it's been an interesting conversation so far, and those two substantive contributions were both very valuable in my view. Not presenting a perspective on the risk equalisation arrangements, which I hadn't seen before, so that was certainly useful for me, and it deserves a wider audience. I'm going to start at a slightly higher level and then sort of circle down into the heart of the discussion, I hope, but I just want to make a few points at the outset. By way of just general introduction, I know Francesco said something about me at the beginning, but just to add slightly, I used to be the CEO of the Private Health Insurance Administration Council, which was the regulator of the private health insurance industry in Australia. VheP, as it was known, had existed for 25 years prior to its abolition in 2015 as a sort of a tidying up exercise of government, and in fact had been around for a lot longer than APRA. It was the original sort of industry-specific prudential regulator of private health insurance. And so obviously at the time of our abolition, we had 25 years of intensive expert experience and understanding of regulation of the industry and a whole range of the policy issues that sat around the industry. So it's good to catch up with Francesco again, who I dealt with a little bit in that role. And obviously I'm very pleased to be able to contribute to this conversation. I will make a starting observation. It's not directed at this group so much, but at the process. I am surprised and a bit disappointed that this conversation, which is so important to PHI, is taking place at such an elite and relatively subterranean level. There are important questions being discussed here. About 50% of Australians contribute to private health insurance and make substantial contributions, $500 or $600 a month, from their back pocket for private health insurance. So that's a lot of Australians who are affected by this conversation and what's going on here. I think the process the department has undertaken so far has been unnecessarily obscure, let us say. Certainly, it's going to have to come out in the open a little bit more as we go along, particularly as we start tweaking these things. My experience as the regulator is that any small changes to private health insurance elicit great alarm and concern in the community. And while it's interesting as actuaries and health economists to twiddle the dial one way or another and just see how things measure out, there's an intense political and human context to a lot of these decisions, which will inevitably play out if any particular course of action is taken. Since I stood down as the CEO of private health of VheP, I've been able, obviously, to speak a little more openly about a variety of aspects of the industry. And I have called on a number of occasions for what I believe would be called root and branch changes. My focus, while I'm fascinated and interested in the way in which proposals are being developed today, my focus is a little higher level. I'm interested in productivity and competition focuses. I think those are major areas of the industry that need to be addressed. The sector is riddled with what I call sweetheart deals, in particular the way in which the prostheses list has been set up and advantages manufacturers, and also what are called the second tier arrangements which service hospitals. If you look at the product in two components, there's the ancillary component, ancillary side, and then there's the hospital side. The hospital side accounts for about 2/3 of premium revenue. And of that premium revenue, if you separate out the administration costs, which are about 8 to 10% per fund, maybe 11%, the residual amount breaks down into 70% or so for hospital admission costs, 15% or so for medical costs, and 15% or so for devices, medical devices, prostheses of one kind or another. So on that analysis, the way in which we look at and analyse what the input costs into the industry through hospital admissions is vital and will remain a key focus. So while we have a system that preserves and protects a whole range of hospitals who are unable to or unwilling to or have set up business models which allow them to rely on a protective floor set at 80% of the contracted rate, then that itself is a massively significant distortionary component in the way in which pricing is set and the way in which the entire industry is done. And in some ways, when that is seen as being a larger issue, sort of moving the dial 1 or 2 notches to the left in terms of settings around risk equalisation is quite a trivial concern. I don't mean to disparage the work that's being done, but I just mean to put things in context. Yet these are fundamental concerns. So my view is that we need to look at a whole range of improved efficiencies across the industry, obviously improve risk equalisation, but not lose sight of the fact that the risk equalisation system as it exists at the moment or as it might change, while it is deficient. In fact, I said to Paolo last night when we were talking about this session that I think it was originally designed by somebody holding a crayon rather than a stiletto or some other more precise instrument. Nevertheless, that needs to be looked at with close and constant sort of awareness of the fact that sitting beside it is our strong national commitment to the retention of some level of effective community rating. And the more you put risk into the equation, the less community rating stands up. And that again is an intensely significant political and personal judgment to be made as we have this conversation. We need to improve the website. We need to junk the rubbish website that we have at the moment, which informs consumers about specialist fees. And we need to improve the quality of information for consumers across the board. Now, in terms of the work that's been talked about today, I only note, because I'm not really in a position to comment in any greater detail, that there was a paper produced by the Melbourne Institute only a week or so ago, which significantly undermines and challenges a lot of the assumptions that have been around the industry for a long time in relation to the displacing effect of private health insurance and its impact on the overall cost of public sector medicine. They did find in their paper, if I understand it in summary, was that there is some measurable amount of difference, but it is not significant and may well not be worth what we're paying for. Nevertheless, I think looking at risk equalisation and considering the way in which it operates at the moment is timely, necessary. It's not necessarily going to attract support. The industry has been historically divided around the way in which the whole issue should be treated. One key sort of point of division has been whether or not we should retain the current claims-based model where the apportionment is made on the basis of claiming history, or whether we should adopt some level of risk-based capitation model where there's some projected assessment of the likely claiming based on history. That even that simple measure, you might call it simple, has been hugely controversial. And as far as I'm aware, the industry is still not resolved that issue, even though perhaps of interest to Hannes, one is the former managing directors of HBF, Rob Bransby, publicly supported a move towards a more risk-based model. However, we'll see. That's never been something that's been able to be happily resolved within the industry, and the government has basically been reluctant to step into that lion's den. So while I find the analysis interesting, and I think that it's useful to have this sort of examination of how things might look if we tweak the dial one notch to the left or one notch to the right, or increase the age perhaps at which risk equalisation cuts in, or perhaps change, reflecting changes in life expectation and so forth. The underlying experience that I want to suggest and insert into the conversation is that almost anything that you want to do in this particular space is highly contested. You have three superly vamped up lobby groups who will insert their point of view at all times, namely the doctors, the hospital owners, and the medical device manufacturers. And of course, the private health insurers are very vulnerable as well. Consumers almost always get trampled in this conversation, and so it's necessary, I think, for all those perspectives to be closely observed. But I welcome this conversation. I think it's been extremely useful.
Very good, thank you, Sean. And indeed, also, I think there are some people from Melbourne in the audience, so please feel free at any point to jump in as anyone else connecting that wants to add comments. So I actually was going to go in that direction as well with the same direction that Sean was going in terms of the next question. I would like to go to Hannes this time around how you see, in fact, in the report, we talk about platform for change. So it's not only a conversation. So obviously, as Sean pointed out, there are a number of different levers here that are being discussed. How do you think, Hannes, this discussion relates to the broader health system discussion going forward and the challenges that the public system here, like in any other countries that have similar tax-based models, are currently facing in terms of accessing to public services, long waiting times, and so on. So what do you see as this conversation contributing into the future role of private insurance in helping improving access to care overall?
Thank you, Francisco. Yeah, I think also, Sean, thank you for your comments. I think there's a lot in there that you said, and your point around the different lobby groups are quite correct. I think there's a lot of interest, and one cannot, as much as we would like to take a technical or academically accurate view on the world, the reality is the world don't work like that, and one have to take consideration of the different objectives in different players. I'm not really can I say well across all the specific public perspectives. So I'll take obviously more my PH I had that I wear in this conversation. So when I take a broad brush view across it, and I do acknowledge that different operators behave differently, so I'm speaking in a broad terms. that in our current system, none of the players, not the government, PHI players, providers or clients, have a direct accountability to consider the cost of treatment options. Clients are not well informed. As Sean has said, there's a big lack of information around what is appropriate for clients, and they often caught in the middle between different perspectives and information. So they're not well informed. They are not incentivized to seek treatment paths that deliver the best outcomes with the least resources. From their perspective, obviously, when the premium is paid, the fund should pay whatever the doctor says. From a medical professional perspective, the focus is absolutely on the clinical information only, or the clinical parts of it, with a very little consideration of the cost. The prosthesis list, as mentioned, is a good example of there's no consideration really of cost, unless it impact obviously the supplier's own pocket, or if there's a co-payment that makes a member not being able to afford a certain course of treatment. So and funds in our current situation is not really empowered. I think that also speaks back to the risk equalization question. You know, it's all good and well to say that funds should be more incentivized to manage claims costs, but there's a limitation in terms of what funds can really do or expected to do. And with this lobby group process, you know, any sort of suggestion that a fund actually steps in and put in control mechanisms to manage the overall cost and funding pocket, the US style managed care is immediately thrown up as a barrier to that conversation or deterrent. So we do need to be very careful in terms of what are the kind of things that will look into the future. So if I step through different players in the market, my perspective is that the PHIs are the most regulated ones. We face extreme amount of scrutiny, and the requirements on data management, on governance, and all of those are on next level in terms of the different players. So as such, I do believe that the PHI are actually probably better positioned than any other role player to play a greater role in getting that cost-effective funding decisions right. That would obviously mean some things that will have to change in the industry. And as pressure, if affordability pressure, and Tom, I do agree with your definition of affordability. In the end of the time, it is what people pay for their premiums. And in the community rated system, whilst it's absolutely true that those people that cost the government more the government will find more value if they are in the private system. What you have to get right in such a market is that need to be value for people who are actually not intended to claim. Those low claimers and people that currently don't use the system, if they're not part of the system, the cost escalation will render it basically unaffordable for those who actually need it. So one do have to get that balance in place. So I do believe that as affordability pressure increase on the system, and it will over time with aging and just the general increase in utilization, something's got to give. And the most sensible development in my mind for the future is for funds to play a greater role in cost-effective funding decisions, guiding members more through the different and getting better outcomes for the money spent. We'll also have to move closer to members, so to understand the members' health journey and any potential claims risk well before it happens. So currently we're a bit blind in the sense that we only pay the claim retrospectively, or we get it as a kind of a passive claims payer at the end of the process. So I do believe there's a lot of value to be had if we are playing a bigger role in understanding consumers' journey, getting more involved in that part early on, and then helping a consumer with the right information to utilize the system in a more cost-effective manner. I think then the PHI will play a better role in actually supporting government objectives for a better system overall.
Thank you, Hannes. Now we're coming to a close. I would like to go around and ask a very direct question and simple, hopefully, which is this: if you had the opportunity to make one change, what would that be? I am tempted to go to Tom first. Please unmute yourself, Tom. My temptation has found a positive response.
At least I have the biggest choice of potential things to mention.
Very good, thank you.
I guess I would say, kind of picking up Sean's remarks, that there are inefficiencies throughout the system. Where do you start? What do you need as a foundation to create incentives for the actors in the healthcare system? And I guess the one thing I would start is to think about the mechanism of paying health plans to encourage them to make cost-effective choices on behalf of their enrollees.
Very good. Sean.
Okay. One from left field, but you'd expect it from me as a lawyer as well. I'd repeal the civil conscription clause of section 23A of the Constitution.
Which
51
says,
and 23A of the Constitution.
which says, briefly, Sean, I know it, but if you can summarize it for the rest.
Well, it's a placidum of section 51 of the Constitution, which sort of provides the Commonwealth Government with power to make a whole variety of payments in the social security space, including health benefits, but which, because of a special deal with the doctors in 1946, resulted in them being protected from effective competition by inserting a requirement that any law not amount to any form of civil conscription, and that's been historically interpreted as basically allowing them to have free rein. So there's very little market forces applying to the provision of medical services in Australia by reason of this long-standing arrangement, and it has distorted the market and resulted in egregiously high medical costs.
Absolutely great. And I would say, thank you, Sean, for saying that. That's a great PhD topic for anyone who's listening there. And I would like to go to Josefa.
So, I mean, I was going to say what Tom said, so I just
That's too easy.
follow on him that payments in private health insurance could definitely be just a way of pushing them to do something that we want them to do. Because if there's nothing that pushes you, financially to move a certain way, I think that's quite difficult. And now just insurers kind of footing the bill afterwards, as Hannes was saying, is not a very productive way to lower cost and to just enhance efficiencies, and also enhance care coordination for patients, and other aspects. So that's just something that I would modify.
So, Josefa, can you give the access to Yuting from Melbourne who would like to raise their hand?
Yes. All right, I think. Yep.
Are Yuting?
Oh, hey. Hello,
Hi.
everyone. This is Yuting from Melbourne Institute. Sean, thanks so much for reading our paper and nice summary to the audience here. I actually have a question for Tom. Hi, Tom. Not been to see you in person, but good to hear your talk. I really enjoyed it. It's very clear. I just wondering, when you do your calculation, have you thought about part of that rebates is not, as we know, kind of the demand for private health insurance is quite inelastic. So we're talking about maybe the elasticity is 0.2, around that ballpark. So basically, a large amount of that rebates is really not increasing the uptake, and mainly only sort of income transfer for the people who are already going to buy it.
Very good.
Usually, I think is the case for the older population and relatively higher income. So I'm just wondering if you think that it might change your calculation quite a lot. Wondering what's your thoughts on that?
Thank you. Tom?
That's along the lines of the critical value analysis. If you knew the demand elasticity for these groups, and you could maybe assume it's 0.2 for everybody, then you would know who's going to be a net winner and loser, because that tells you how many people go in and out in response to a dollar change in subsidy.
That's very good. And you think very good point. and just to add to it, so we just look at this statically. Obviously, the elasticities. What I would have said if I were asked the question that I asked the others, what would I do next? Is in fact to study exactly that more in depth and to really look at this dynamic effect. So thank you, Yuting, and I would go now to Hannes.
Thank you, Francisco. I already, I think, spoke quite a bit in terms of the future of PHI. For me as well, that shift of insurers moving from more passive payers to being more active, involved in actually managing the overall claims cost in the system. And I think with that, there's a number of things that will have to happen to enable that. And I would like to see that innovation also coming through.
Very good.
Yeah. Thank you.
Very good. So insurers almost as purchasers of care in a sense, or something like that. Very good idea. Now, last but not least, our international guest that made it all the way from Switzerland, Lucas. You can take your time also to suggest and close.
Okay, thank you. I have, what is left after all these important topics? I really liked Sean's point of when he was talking about what's going on in the Australian market, and I was like, well, is he speaking about Australia or Switzerland? Because we have exactly the same problems. In like as he said, it's a huge problem or a huge amount of money involved, and people don't really understand it. And so my point here would probably be like how to increase the literacy of people of the system of like understanding what they're really buying, what is really like how it is really going on. And it's something that I'm starting to look at in Switzerland too, that like we have the system, but a lot of people don't really understand. They're forced to buy it in Switzerland. They cannot choose it. Here it's more like they can have a choice. But we have also the system of the mandatory part and the supplement part, and then you mix it up, what is really what covers really what. So I think to have competition in a market, you really need consumers to be informed and to know what they're actually choosing. And I would say that that's something I would pay attention to, that you inform consumers of how the system works and what they're actually gaining, and what their money is worth.
Very good. So any points from the audience here? Comments? No? Very good. So let me thank you, or not, maybe, I don't know. We're running out of time. I'm sorry. It's always, time is always quite pressing, even if we dedicated over 1 hour and a half to this. It's a lot of content. It's a lot of things to absorb. But I'd like to thank everyone that presented today, and also those who have attended in the multiple ways to connect online that we had. Of course, I received a few emails that I will address later on with some questions. Also, would like to point out that all the reports can be found on the Department of Health website. I think also to comment on Sean's discussion about what next in terms of having this debate more probably in the public eye. I suppose the consultation process has ended very recently, I think a few days ago. So now there will be, I think, ample opportunities, and this series of seminars, of course, will contribute to that. And hopefully with other organizations, we are also trying to inform about what's being discussed in relation to this. And you might have heard yesterday that the New South Wales government also has announced quite an important commission to, in fact, look at how to reorganize health funding across the board here. So things are happening. So hopefully this conversation or this platform for change can, in fact, grow. So thank you once again, everybody. And thank you, Jennifer and Sifa, for co-branding and for being here today. And also thanks for the Institute of Regional Futures and Roberta Ryan for branding this, and for the Business School and the College of Human and Social Futures to host this event here in New Space. Have a great day and interact with us. You'll find us online. Any material or questions, come to us. Good night to the US guys. Really, really thanks. Have a good day to Perth and Canberra. Bye. Well done. Very good.